Okay, good morning, everyone, and welcome to Friday morning meeting. So, Dr. Wing, who's one of our fellows in the Gastroenterology department, is going to talk to us about something which is very common. As you can see, you see for yourself the title over there. So, over to you, Jess.
Okay, so good morning, everybody. I'm Jessica. I'm one of the gastroenterology fellows at Wits DGMC and Charlotte McCulloch. So today I'm going to be speaking about gastroesophageal reflux disease, which is a burning and bothersome problem for both doctors and for patients. So let's get started. So why are we talking about this topic? So firstly, it's a very under-recognized morbidity and it has a very high prevalence. So population-based studies estimate worldwide prevalence to be around 13%. In Western countries, around 20%, more prevalence in Southeast Asia and in Southeast Europe. And unfortunately, there's no prevalence data from Africa. It also is a great mimicker. It presents with a wide variety of clinical presentations and can be quite diagnostically difficult to diagnose. It offsets a substantial economic burden on our country and worldwide. The PPIs were once the second most worldwide sold pharmaceutical item. And there are new treatment options available to tackle this morbidity. Okay, so let's just go through some definition and terminology that I'll be using throughout the presentation. So the definition of gastroesophageal reflux disease is reflux of the stomach contents into the esophagus, causing troublesome symptoms and/or complications. So it's normal physiologically to have some degree of reflux, daily, normally postprandial. They're asymptomatic and short-lived. However, if it becomes pathological, if it causes troublesome symptoms and/or complications, and we'll get to conclusive evidence later. So there are two subclassifications of gastroesophageal reflux disease. There's ERD and NERD. So we'll speak about that a lot in the gastro department. So ERD is erosive esophageal reflux disease. That means that you have visible breaks in your distal esophageal mucosa with troublesome symptoms. So you can see mucosal breaks endoscopically. Non-erosive gastroesophageal reflux disease, or NERD, is presence of those troublesome typical symptoms without visible esophageal mucosal injury. So NERD, which is the majority of our patients. Okay. Okay, so looking at some of these clinical features, these troublesome symptoms that the definition includes. Typical symptoms only include two symptoms. So it's a heartburn or esophageal chest pain. So that's the typical retrosternal burning chest pain, typically postprandial, more than 2 days a week. And then regurgitation, which is perception of effortless flow of gastric contents into the mouth. Those two in red are important because that comes into our diagnosis later for the general physician when we go down the algorithm. Less typical symptoms include water brash, adonophagia, dysphagia, globus sensation, and nausea. So I don't know, many people know what water brash is, but essentially it's ejection of saliva from the salivary gland in response to reflux, and it can be as much as 10 mL of saliva. Quite uncommon. And then globus sensation is the constant perception of a lump in the throat, which is also sometimes an atypical symptom of GORD. Then looking at our extraesophageal manifestations, these usually are pulmonary, so it's asthma, a chronic cough, aspiration pneumonia, long-term bronchiectasis, interstitial pulmonary fibrosis, bronchitis, and then sleep disorders, especially associated with obesity, such as obstructive sleep apnea, and then posterior laryngitis. Okay, as I said, it's a great mimicker. It can present with similar signs and symptoms to these entities. So esophageal causes would be Zenker's diverticulum, other forms of esophagitis, such as eosinophilic esophagitis, pill esophagitis, and infectious esophagitis, and then motility disorders such as achalasia. Then don't forget extraesophageal causes, so that's gastroparesis, cholelithiasis, peptic ulcer disease, and then functional dyspepsia, or the new term is disorders of gut-brain interactions, and then angina pectoris. Some of the risk factors, so there are genetic risk factors, not very common. They are clustering in families of GORD and Barrett's, and then in twin studies done in Sweden and the USA, there seems to be genetic liability for around 30 to 40%, so quite high. And it seems to be related to smooth muscle disorders associated with developing a hiatal hernia, a reduced basal lower esophageal sphincter pressure, and impaired motility. Then environmental, interestingly enough, tobacco and alcohol consumption actually have a weak correlation with symptoms, but in terms of endoscopically are a strong risk factor for erosive esophagitis and adenocarcinoma of the esophagus. So just for the general physician, to suspect GORD in these following clinical situations, they have a strong association. So in pregnancy in the first trimester, systemic scleroderma, Zollinger-Ellison syndrome for us gastros, prolonged nasogastric tube intubation, post-Heller's myotomy or POEM, which is a per-oral endoscopic myotomy, which is used to treat one of the treatment modalities for achalasia and other motility disorders, then post-bariatric surgery and obesity. I gave obesity its own slide because BMI is directly proportional to the prevalence of both GERD symptoms and esophagitis. Reasons being, there's increased intragastric pressure that overwhelms the anti-reflux barrier. There's an increased prevalence of hiatal hernias in obese patients. There's a lower esophageal sphincter pressure. This is because visceral fat secretes interleukin-6 and TNF-alpha, which are modulators of your lower esophageal sphincter. And then high caloric meals, which obese people tend to eat, are associated with delayed gastric emptying, increased frequency of your transient lower esophageal sphincter relaxations, which I'll chat about later. It's part of the pathophysiology, and then fundic distension. Unfortunately, treatment for obesity, so sleeve gastrectomy, is also associated with increased GORD symptoms, esophagitis, and prevalence of Barrett's esophagus. Okay, so the pathogenesis I try to make simple. I find it easier to divide them into two columns. So it's an imbalance between esophageal defensive factors, then aggregating factors refluxing from the stomach. So your imbalance between your esophageal defensive factors are three. So it's your anti-reflux barrier, which I'll describe now, your esophageal clearance mechanisms, and then your tissue resistance. And then aggressive factors include the degree of gastric acidity, your volume, and if there's duodenal content present or not in the refluxates. Okay, so these are the anatomical parts which make up your anti-reflux barrier. So it's your intrinsic lower esophageal sphincter, your diaphragmatic crura, and the phrenoesophageal ligaments, as well as the acute angle of His. So this anti-reflux barrier determines both the volume and the frequency of esophageal reflux, so not the duration of exposure of the esophagus to acid. So these are four mechanisms which are considered failure of the anti-reflux mechanism. And this is one, decreased basal lower esophageal sphincter pressure, transient lower esophageal sphincter relaxations, which are the most common basis for pathophysiology, and then swallow-associated lower esophageal reflux, lower esophageal sphincter relaxations, and then the presence of a hiatal hernia. I'm not going to go into each of these individually because it's beyond the scope of this presentation, and it's mainly for gastroenterologists to understand. This is just a slide to show you the anti-reflux barrier. So it's the acute angle of His, your diaphragmatic crura, and the phrenoesophageal ligaments, as well as the lower esophageal sphincter. So this makes up the anti-reflux barrier. Okay, then this is a table from the Harrisons of Gastroenterology, Schleisinger's. It's a nice table just showing your hormones, your neural agents, foods and nutrients, and other factors that are associated with decreased or increased lower esophageal sphincter pressures. So as you can see, chocolates, fats, peppermints, all decrease your ileus pressure, increasing esophageal reflux. And then common drugs that we use, calcium channel blockers, morphine as well, can also contribute to esophageal reflux disease. Okay, then moving on to the next pillar of esophageal defensive factors that fail. So your esophageal clearance mechanisms are very important. These determine the duration of the acid exposure to the esophageal mucosa and the severity of injury. So your anti-reflux barrier contributes to volume and frequency of reflux. This contributes to your duration of acid exposure. So there's two mechanisms. There's volume clearance and then your salivary and esophageal gland-based titration. So volume clearance is the food bolus just being cleared by peristalsis. So if you have failed peristalsis or weak peristalsis, usually less than 30 millimeters of mercury, you'll have increased risk of GORD and exposure to acid. Then your saliva and your esophageal glands secrete a base, and this neutralizes residual acid after peristaltic contractions. So this is important for elderly patients on anticholinergics, anybody with xerostomia, Sjogren's, scleroderma, and this is why we sometimes use lozenges or ask them to chew gum to increase salivation. Okay, last pillar of esophageal defensive factors is your tissue resistance. Just quickly, it's pre-epithelial factors. So your esophageal mucosa does secrete prostaglandins and mucin. This may play a theoretical role. There's epithelial factors, which are your pumps. They transmembrane protein exchange pumps, and they maintain intracellular pH. Tight junctions seem to be very important. Histologically, both with NERD and ERD, you see dilated intracellular spaces. So it's non-specific. You can't differentiate between NERD and ERD. So those dilated spaces are part of the pathophysiology. Then post-epithelial factors, so increased blood flow, transporting nutrients, oxygen and bicarb, removing your hydrogen and your carbon dioxide. This increases response to luminal acid. So this is also a factor in clearing your refluxate. Just quickly, so 70, like I said, most of our patients with GORD have NERD or non-erosive reflux disease. It means that there's no visible endoscopic breaks, just a reminder on endoscopy, but they do have specific microscopic alterations of the mucosa. So there's the integrity of those tight apical junctions. You have increased permeability in those dilated intracellular spaces again. And the reason why they seem to be more symptomatic is because they have more superficial sensory nerves that are express a certain receptor that are activated by these hydrogen ions. So they're more sensitive to acid. In terms of esophageal reflux disease, you get basal cell hyperplasia as well as your dilated intracellular spaces on histology, and it's indirect. So it's C cell infiltrate into the mucosa, and then via chemotaxis of inflammatory cells, you get cell death of your mucosa. And sometimes these patients will have severe erosive reflux disease on endoscopy, but won't have symptoms. And this is because they have deeper sensory nerves that are required for stimulation. Okay, so looking quickly at our gastric factors, on the other side. So we have something called an acid pocket. We all have it. It's an area just below the esophageal gastric junction, and it escapes the buffering of our meals. And this allows chronic short segment reflux episodes. And this is where Gaviscon, alginate, antacids may work. And then interestingly, H. pylori infection of the corpus, specifically your CAG-A strains, can be protective against GORD. So they cause chronic inflammation, that cause gastric atrophy of your parietal cells and less acid secretion. Your H. pylori organisms also produce ammonia and increase gastric alkaline secretion. But conversely, if it's the infection of the antrum, there's increase in gastrin production, thereby increasing the risk of GORD. So dependent on the location of your infection, you might be at an increased or decreased risk of GORD. Just as a mention, please, even if it's in the corpus, still treat the H. pylori because there is a high risk of adenocarcinoma. So please do not treat the H. pylori of the corpus to protect your patient from GORD. Okay. Then looking at motility factors, so abnormal fundal accommodation of the proximal stomach and recovery of tonic tone has a role in gastroesophageal reflux disease, but there's poor correlation between symptoms, actual esophageal acid exposure on pH studies, but it is noted in 40% of patients with GORD. So it's not conclusively shown, but there is an association. And it may be a factor in contributing to proximal extent of the reflux rather than total acid exposure. And just be aware that this is common in women and diabetics. So they get secondary reflux from gastroparesis. Okay, and then lastly, our last aggregating factor from the stomach is the actual type of refluxate. So you get acidic, weakly acidic, and then GRAS refluxate. Acidic refluxate is a pH less than 4. And obviously here, your perception of heartburn and regurgitation is increased. And the more prolonged it is and the more proximal exposure it is, the more symptomatic the patient will be. And here, obviously, there will be mucosal damage, especially if bile acid is present. If you have weakly acidic or non-acidic refluxate, you'll see NERD most likely, so you won't have mucosal damage, but it is implicated in chronic cough and then in regurgitation. And then lastly, gas refluxate can be supergastric or gastric. And this is important to differentiate because the treatment here is actually behavioral therapy. Okay, so this is a psychological symptom. Okay, then lastly, your perception of esophageal symptoms. Each of us perceive gastric reflux differently. This is because of our psychoneuroimmune modulation in the gut-brain axis. This is precipitated by psychological stress, sleep deprivation, like Professor Paget said, anxiety, stress, and this relates to hypersensitivity of esophageal nerves via those dilated spaces that I spoke about earlier. And then some patients have hypervigilance, so they have autonomic system arousal, and this is a cause of refractory GORD. Okay, so look, getting to diagnosis now, this is an important slide that is from the Lyon consensus. So it's new updates on gastroesophageal reflux disease. And this is for the general physician. So When a patient presents to you with typical symptoms, so it's only that heartburn, that regurgitation, and the esophageal chest pain, no other symptoms. Those are the only typical symptoms, and they don't have alarm symptoms, which I'll talk about in the next slide. This is the only area where you can give an empiric trial of anti-secretory therapy, so a PPI or a histamine 2 receptor antagonist. If you have more atypical symptoms such as belching, like we spoke about, the globus, the nausea, dyspepsia, you need conclusive evidence before you can attribute these symptoms to a reflux basis. So you need to go into endoscopy, pH impedance studying, monitoring, and then as an adjunct, high resolution manometry. And then also don't refer everyone with a chronic cough, asthma, posterior laryngitis to us. First do a pulmonary evaluation, do an ENT examination first. So the main purpose of the slide is to show that if you have no alarm symptoms and only those 3 typical symptoms, which is heartburn, regurgitation, esophageal chest pain, can you give an empiric trial of anti-secretory therapy without alarm symptoms. So these are alarm symptoms. So if your patient has evidence of GIT bleeding, so if it's melena is present, hematomesis, hematochezia, if there's occult stool blood in the stool, iron deficiency anemia, unexplained unintentional weight loss, dysphagia, odynophagia, persistent vomiting, and gastrointestinal cancer in a first-degree relative. If they have atypical symptoms, you can still refer these patients for conclusive workup. Okay, so what constitutes conclusive evidence on endoscopy? So it's Los Angeles grades B, C, and D esophagitis. I'll show you a picture of those. If you have biopsy-proven Barrett's, and if you have presence of a peptic stricture, only these 3 are conclusive evidence endoscopically for gastroesophageal reflux. In unproven GORD, you should keep your patient off anti-secretory therapy for 2 to 3 weeks before they get endoscopy. Otherwise, we might underdiagnose them. And then in the setting of refractory GORD, if you still have a Los Angeles grade B or higher, as well as a peptic stricture while on optimized PPI therapy, that's refractory GORD endoscopically. So let me just quickly show you a picture of the Los Angeles classification. So it would be B, C, and D, which would constitute as GORD as evidence, not A. So B is when you have mucosal breaks that are not more than 5 millimeters that do not bridge the top of the mucosal fold. So this is the gastroesophageal junction here, and we're talking about these little breaks here. So if they do not bridge the tops of the folds, but they're more than 5 millimeters, this is considered conclusive evidence of GORD. If they do bridge, these breaks do bridge the top of the mucosal folds, but involve less than 75% of the circumference of the esophagus, that's grade C. And then D is when they bridge the top of the folds and involve more than 75% of the circumference. So it's these three grades that constitute GORD. And then if you look at the other conclusive evidence, it's your peptic stricture, as you can see here, Barrett's esophagus, and then this is just adenocarcinoma in the setting of Barrett's esophagus. So it's peptic stricture, Barrett's esophagus, which is biopsy proven, and then your Los Angeles grade B, C, and D, which constitute endoscopic features of GORD as conclusive evidence. Okay, now getting to ambulatory reflux monitoring. So the gold standard is prolonged wireless pH monitoring. So it's a wireless capsule that we place 5 centimeters above the LES. And remember, it's off anti-secretory therapy. It gives us our highest diagnostic yield. The study duration that seems to be best is 96 hours. It determines if you have physiological or pathological acid exposure time, so AET. It's not widely available. We have the catheter-based pH monitoring, so via the nose. It is a viable alternative, and these are some of the parameters which are conclusive for GORD. So if you have an acid exposure time of less than 4 on all of those study days, and you have negative symptom correlation, that excludes GORD. So that will be your functionals. Then if you have an acid exposure time of more than 6 for more than 2 of the study days, that's diagnostic of GORD. If it's less than 4%, but there's positive reflux association with each of those acid exposure times, that meets criteria for reflux hypersensitivity. So patients on functional, they have hypersensitivity. And then between 4 and 6% is considered inconclusive, and you need further testing. Okay, then this is impedance monitoring. So this is pH monitoring plus impedance. Over here, it has diagnostic value in unproven GORD when you're off anti-secretory therapy again, when you have typical symptoms that are associated with the supragastric belching, pulmonary symptoms, and rumination. So rumination is when a patient subconsciously regurgitates their food, rechews it, and reswallows it. It's unconscious, but it has a psychological basis. So it also has the advantage just to plain pH monitoring because it picks up more reflux episodes. So it picks up more weakly acidic reflux episodes. So it has a higher sensitivity because of the impedance component, but you need experts interpretation to overcome erroneous automated analysis. And it shifts the diagnosis again from functional heartburn to reflux hypersensitivity. And then looking in if you've got refractory GERD or unproven GERD and you've got persistent symptoms, it's very helpful there. It helps us gastroenterologists make a decision about escalating therapy or management beyond pharmacotherapy. And then a total of more than 6 is a diagnostic, again, of pathological GERD with the impedance component. And then these are some other parameters. So usually a reflux episode of more than 80 a day is adjunctive evidence for GERD. And if it's less than 40 a day, it's adjunctive evidence for absence of GERD. Okay, we'll go into the others for time reasons. And then looking at high resolution esophageal manometry. So typically it's actually not indicated in evaluation of uncomplicated GERD. It's very useful for us when we're trying to locate the LES when placing our impedance catheter, but it detects indirect markers of GERD. So it'll detect compromised peristaltic function. Remember I said esophageal clearance is part of the pathogenesis. So you can see indirect markers. So compromised esophageal peristaltic function and of normal anti-reflux barrier, so an abnormal esophageal gastric junction morphology, and then barrier function. So they provide indirect markers. It's used in evaluation of refractory symptoms for GERD and to document adequate peristalsis and to rule out motility disorders such as achalasia, scleroderma, especially before anti-reflux surgery. Do not refer patients for anti-reflux surgery without manometry. So complications of GERD are quite rare. 0.46 per 100,000 persons. You can get hemorrhagic esophagitis and ulcer perforation or rupture, aspiration pneumonia. But the 2 most important are esophageal strictures and Barrett's esophagus. I'm not going to speak about these because these 2 are both huge topics on their own and more applicable to gastroenterologists. But if you'd like, I can do that in the next meeting. They're also quite interesting. Now moving on to management. So this is just a nice diagram showing the hierarchical approach to management. So we start off with lifestyle interventions, then going to our anti-secretory therapy, then going to adjunct therapy, and eventually to endoscopic and surgical therapy, which we'll speak about now. So lifestyle modification. So we've all heard about telling your patient not to eat 3 hours before going to bed. We've told them about lozenges, chewing gum to increase salivation, to avoid peppermint chocolates, all of those kind of lifestyle interventions. However, these actually have no conclusive evidence. There's only 3 lifestyle interventions that have conclusive evidence in case-controlled studies only, and this is weight loss, sleeping with your head elevated, and lying in the left lateral decubitus position. So it's only those 3 lifestyle modifications that have shown to have some improvement in GERD. Then moving on to pharmacotherapy. So we can look at over-the-counter antacids. They have a rapid onset and relief of heartburn, but require frequent use. So this is our Gaviscon. And actually, Gaviscon proves to be better, the relief, than placebo, with actually a small number to treat of only 4. Of course, this does not address esophagitis, so it doesn't treat erosive disease. Okay, it's just symptomatic, and that will also target that acid pocket that I spoke about earlier. Okay, looking at prokinetics, so in the setting of gastroparesis, this may be helpful. So looking at metoclopramide, cispiride, macrolides such as erythromycin, all of these increase our LES pressure, improve gastric emptying and esophageal clearance, but their effectiveness decreases with disease severity. It has no effect on our major cause of anti-reflux barrier failure, which is our transient LES relaxations, and it's unreliable again in treating erosive disease, and it's limited by side effects. Okay, GABA agonists. So baclofen, we can also use as an adjunct, 5 to 20 milligrams per TDS. They decrease your most common pathological cause for reflux, which is your transient lower esophageal sphincter relaxations again. They also decrease acid and duodenal reflux significantly. They improve symptoms in patients for 4 weeks, about several months, but their major limiting factor is tolerability. So patients complain of presyncope and drowsiness a lot, then nausea and vomiting. So our baclofen and placable have actually been formulated to improve tolerability, but they have no clinical efficacy. So they've been abandoned. So we only use baclofen. Okay. Then looking at our histamine 2 receptor agonists, so we have cimetidine available from our pharmacy now and then. It's more effective in controlling nocturnal rather than meal-associated acid secretion. So meta-analysis found that overall esophagitis, so erosive esophagitis, rarely exceeded 60% after 1 to 2 weeks, but they're valuable to add on for patients with nocturnal acid breakthroughs on a PPI. So if you're doing ambulatory monitoring, you can pick up nocturnal breakthroughs. This would be the patient where you add on PRN histamine 2 receptor antagonists. And I say PRN because tolerance develops. They have tachyphylaxis, so only use it on a PRN basis, and it has a very safe side effect profile. Then getting into the main character, which is our PPIs. Okay, so PPIs, remember, treat the number of acid reflux episodes, but they do not treat the proximal extent of the reflux nor regurgitation. So volume regurgitation is not treated by PPIs. It's robust in treating heartburn, usually within 1 to 2 weeks. They're superior in maintaining your intragastric pH of more than 4 for about 10 to 14 hours compared to your histamine 2 receptor antagonists, which only suppress intragastric pH for about 6 to 8 hours. A Cochrane analysis found that they're superior to your histamine 2 receptor antagonist and placebo in both erosive and non-erosive disease, as well as undiagnosed reflux symptoms in primary care. And then a large meta-analysis showed complete healing of erosive disease and severe esophagitis after 8 weeks in 80% of patients, compared to 51% that are using histamine receptor antagonists and 28% with placebo. So they do work. They definitely work. Okay, and then in terms of erosive disease, so this is PPI therapy in the context of erosive disease. They're more efficacious in initial healing as well as in maintenance. So they're more efficacious than your histamine 2 receptor antagonists in maintaining remission over a 6 to 12-month period. But unfortunately, after esophagitis is healed, recurrence occurs in about 80% of patients with severe esophagitis and within a 6-month period after being stopped. So this is some rationale for continuing indefinite PPI therapy in patients with severe erosive disease, not non-erosive disease. So there was an open, compassionate use data from Australia and the Netherlands, which supported indefinite PPI therapy for patients with severe erosive disease. So they all stayed on their PPI therapy and they maintained remission for 11 years. Relapses were rare, strictures did not occur, and Barrett's esophagus did not progress. Then looking at our American Gastroenterology Association clinical update guidelines, this is more in terms of the non-erosive disease, where you have patients with typical GERD symptoms. As a physician, you say, okay, they've got heartburn, esophageal chest pain, regurgitation. I'm going to give them a single dose PPI for 4 to 8 weeks. We give it for 12 weeks, so 3-month trial, and then we assess the response. If they have a sustained resolution of their symptoms, we try to wean to the lowest dose and then try to actually wean them off therapy, so in non-erosive disease. And then if they have a partial no response to symptoms, we're going to speak about that. How can we optimize our PPI? So you optimize your anti-secretory therapy, and then again, assess the response in 4 to 8 weeks. But this is in the setting of non-erosive disease. Okay, so proton pump inhibitors, important basics before we go on to how to optimize them. So they irreversibly bind to our hydrogen potassium ATPase pump on the luminal surface of the parietal cell, which is the final stage of gastric acid secretion. It's actually a prodrug, so it requires an enteric coat to withstand degradation by a gastric acid. So once it's absorbed by the duodenum and in the plasma, it's only activated in the secretory canaliculi of the parietal cell. So it's a prodrug. It's metabolized by the liver primarily by cytochrome P452C19 and to a lesser extent by CYP3A4. This is important later for why some patients might fail PPIs. So different formulations have a similar structure and a mechanism of action, but there are differences in their pharmacokinetic properties. These differences are quite small, theoretical, and their clinical relevance hasn't really been established. So switching between PPIs, we'll talk about now. Okay, so why is my patient not responding to a PPI? So you've seen your patient, you've given them a trial of PPI, and they're still complaining. One of the major reasons is that doctors prescribe PRN dosing rather than not daily consistent dosing when initiating symptoms. So not when you're trying to wean them off, when you're initiating. So PPIs, remember, only inhibit activated enzyme present in the canalicular membrane. So all those inactive membranes will still be recruited and you'll still have acid secretion, but at a reduced level. So you have to give consistent dosing to suppress more pumps. And this is one of the reasons why patients fail PPIs, because they use a PRN and not daily and consistently. Okay, and then the second reason is your timing of administration. So the greatest amount of your hydrogen potassium ATPase pump is after a prolonged fast. This is when you have the most pump available, and thus we should administer it 30 to 60 minutes before the first meal of the day. Okay, people take it at all times of the day. And then like I told you about how it's metabolized, you have slow and rapid metabolizers. So if you're homozygous, you have genetic mutations for your CYP2C19, 30% of South and East Asians and 5% of Caucasians are slow metabolizers, which is great. So they have a greater duration of acid suppression. And then this means that we can dose reduce our PPI. Then the converse applies for those that have rapid metabolizers, although the literature for rapid metabolizers isn't as clear as slow metabolizers. Okay, switching PPIs. So there's significant individuality and variability in intragastric pH control between different PPIs. Generally, in terms of intragastric pH control, this is theoretical. Esomeprazole is more potent than rabeprazole, more potent than omeprazole, lansoprazole, and pantoprazole. So what we have available at CMJAH is only pantoprazole. We don't have lansor anymore, so we have pantoprazole. There's no consistent difference in relation to symptom resolution and esophagitis healing rate. So in terms of clinical relevance, no difference, but theoretically, yes. Then, so switching PPIs, multiple switches is not recommended, especially in patients with well-controlled symptoms. It actually may increase symptom severity and decrease patient satisfaction. And you can change it, so for example, in private for cost-saving purposes. Okay, so how do we position our PPI use for success? This is just a summary. As I said, they're acid label molecules. They're not all constructed the same. There's varying levels of intragastric pH control. What we can do is we don't recommend multiple switches. We ensure that they are taken before breakfast, at the first meal of the day, ensure that it's consistent and not PRN dosing. And if you must switch, try to choose one with a theoretical potential for greater intragastric pH suppression and less metabolism via your CYP2C19 enzyme. So getting to controversies, there's multiple controversies about PPIs. There's a risk of cancer after Helicobacter pylori treatment. This is due to atrophic gastritis. Then risk of infections, enteric infections, pneumonia, C. difficile, spontaneous bacterial peritonitis in cirrhotic patients, COVID-19, absorption, metabolism of minerals and vitamins, so B12, iron, calcium, hypomagnesemia, bone fractures. For the cardiologists, effect on their plavics. And then for the nephrologist, there's a fear of interstitial nephritis, renal disease. Then for us, colitis, celiac disease, myocardial infarct, strokes, dementia, and early death. So quite a lot. So basically, the summary of this is that what I found is that most of these were identified by weak association in observational studies, and they cannot establish cause and effect. We can't exclude the possibilities that PPIs might confer a small increase in developing these adverse effects, but there was only one high-quality study which established a modest but significant association of PPIs, and that's with enteric infections. And then obviously most GI specialists would agree that there are well-established benefits of PPI that far outweigh these theoretical risks. So why do we need new treatment options? As I said, PPIs are prodrugs. They must first be activated by gastric acid to covalently bind to our proton pumps. They only affect our actively secreting parietal cells. It has a short plasma half-life, so we need to have repeated and consistent dosing. Our stomach actively regenerates new pumps about 25% in 24 hours, and it's got a lot of variability with metabolism via the CYP2C19 enzyme, and there's multiple drug interactions. So the new kid on the block are potassium competitive acid blockers, or PCABs. These are acid stable. They do not require enteric coating. They're active drugs. They're not prodrugs like the PPIs. They also inhibit our potassium hydrogen ATPase pump by binding ionically to it. And they bind both, importantly, active and non-active proton pumps. So they're much more potent, and there's no need to dose around meals then. And they're not primarily metabolized by our CYP2C19. So these are the pipelines of some of the PCABs. As you can see, none are in South Africa yet, mainly in South Korea. Okay. So PCABs are an option for refractory GERD. So if you've got severe reflux esophagitis, LAC or D, who do not heal on optimized double-dose PPIs, we can use them. Patients who are not good candidates for anti-reflux procedures due to their comorbidities, if they have motility issues, both esophageal and gastric motility issues, and with documented abnormal acid exposure on double-dose PPI with reflux-related symptoms, so for refractory GERD. Just to clear up some terms, so persistent symptoms while on optimized therapy in the context of proven GORD is referred to as refractory symptoms, not GORD. Refractory GORD again requires conclusive evidence, so it's endoscopic LABCD esophagitis or a recurrent stricture while on optimized therapy, or on your impedance studies, an acid exposure time of more than 4% and 80 reflux episodes a day on optimized anti-secretory regimen. So it's not based on symptoms for referral. Okay, then a management to approach your refractory GERD, it's the same as your approach to GERD. You go through all the things again: lifestyle measures, optimizing your anti-secretory therapy, adding on a histamine 2 receptor antagonist, adding on Gaviscon, adding on other alginates, using baclofen if your basis, your main pathological basis on pH manometry and impedance studies is your TLRESs, and then going on to invasive GERD management, which is anti-reflux surgery and endoscopic procedures. Okay, so quickly, surgical options, anti-reflux surgery. This is a Nissen procedure or a toupee, which is a partial fundification, and the Nissen is a full fundification. It increases your basal LES pressure, decreases those transient lower esophageal reflux sphincter relaxations, and inhibits complete LES relaxations. It's comparable to long-term efficacy to PPI in multiple randomized trials, but it may be superior in terms of symptomatic relief in refractory GORD. In terms of long-term monitoring, sustained relief is shown for up to 17 years off PPI therapy. Complications with any surgery can be expected, so they might need to re-intervene for recurrent GORD and fundification failure. Gas bloat syndrome is a problem, dysphagia, and then post-operative obstructive symptoms. And then looking again at anti-reflux surgery, but the laparoscopic version. So unfortunately, post-operative, you still need to use PPI use in up to 43% of these patients, and there's a 17% risk of recurrent GORD. You can do, the next procedure is a Roux-en-Y gastric bypass. So this is for refractory GORD, if there's a failed fundification, and if there's refractory GORD following a sleeve gastrectomy in obese patients. Then complications, again, gas bloat syndrome, dysphagia, obstructive symptoms, and then having to re-intervene surgically. Then this is another surgical option, which is called magnetic sphincter augmentation. It's a magnetic bracelet that's encased in titanium. So it's a little bracelet that's implanted around the esophageal gastric junction. And 58% of patients normalize their acid exposure time within a year, and 90% halve their PPI use. So you'll have favorable outcomes if you, on your workup, so on your pH impedance studies, if you have more than 80 total reflux episodes a day. It's particularly favorable in patients with regurgitation predominant symptoms, so those that have regurgitation or volume reflux. And it's got a sustained improvement in a five years post-implantation. And then mild dysphagia does occur with 98% at 1 year and 96% at 3 years. So this is what it looks like. This is the titanium bracelet that is actually placed around the esophageal gastric junction. Okay. And then who are good candidates for anti-reflux surgery? So those with severe reflux esophagitis who do not want to take PPIs indefinitely, this would be in the first world. So LAC and D, typical GERD symptoms that who cannot be weaned off their PPIs and do not want to take PPIs indefinitely, again, first world problems. If we've got troublesome regurgitation and then PPI refractory heartburn, that is clearly reflux related. So you have to have a meticulous workup that includes your reflux monitoring. These are good candidates. So please refer to us before you refer to the surgeons. Okay. And then looking at endoscopic options. So this is something that we do as gastroenterologists. So anti-reflux mucosectomy. This actually, so it's similar to the magnetic braces, but we create scarring around the esophageal gastric junction using concentric or circumferential resection. And we can add mucosectomy or ablation using argon plasma coagulation. So observational studies have shown that there's improvement in reflux-related quality of life, and there's a pooled success rate of up to 73%. But it's only over short-term follow-up. It's relatively new, and you can get post-procedure dysphagia requiring dilatation in 10% and perforation in 2%. And then transoral incisionless fundification, or TIF. So this is basically doing a fundification, but endoscopically. So it's involving 180 and 270 degree fundification of the gastric esophageal junction. It placates the proximal portion of the stomach and accentuates that angle of his. And the long-term effect is not established. And then the last thing that we can do is a GPOM, which is a gastric peroral endoscopic myomectomy, which is something that Dr. Lala does. And this can be considered in a subset of patients with refractory GORD and gastroparesis specifically. Okay, these are my references, and any questions?